Started. Welcome to our Suicide Care Research Center monthly public talks. We do these 9 to 10 Pacific, 12 to 1 Eastern on the first Wednesday of every month, wanting to kind of bring expertise into the center and to our larger SCRC community, including our advisory boards and multiple other collaborating scholars who we work with, but also bringing our work out to the public. So today we will be hearing from our own Julie Goldstein Grummett, who is the co-chair of the Policy Core here at SCRC, so known to many of you. In her day job, Julie is the director of the Zero Suicide Institute and focuses on the development and the evaluation and the effective implementation of the Zero Suicide Framework nationwide. And she's also the vice president at the Education Development Center. And we also have Dr. Deb Stone, who's Senior Director for Knowledge and Review at the JED Foundation, following about 18 years doing suicide prevention at the CDC. Uh, and today they are going to be presenting to us on the national strategy and giving us, again, a larger, as we really try to focus with our policy core, being sure that all of us on the research side of the house have a really good understanding of what is happening in suicide prevention at the national level so that we can be sure that our research fits into the larger picture. And with that, I'll hand it off to you, Julie.
Thanks, Kate. Let me get my... All right, let me know you're seeing my slides as a full slide.
Yep.
Perfect. Okay, so I'm Julie Goldstein Grummett with the Education Development Center. Part of my role at EDC is I oversee our suicide prevention work. It includes the Zero Suicide Institute, but it also includes the National Action Alliance for Suicide Prevention. And I just want to give you a brief overview because I'm not sure everybody's familiar with the National Action Alliance. So who we are. So we are the nation's public-private partnership to advance suicide prevention. So what that really means is, we have the public sector. We have CDC, SAMHSA, HRSA, Homeland Security, all different entities that have a role in publicly advancing suicide prevention, and they've been at it for many years, right? Those are sort of your usual partners that you think about advancing suicide prevention. But really, we think about who are our private partners, and not just nonprofits, but everybody is impacted by suicide across the country, whether it's at work, whether it's in your community, whether it's with faith. The nation's railroad is one of the biggest employers of individuals in the country. So the railroad industry sits on the Action Alliance, the executive committee, the entertainment community, technology group. So we recognize no one entity is going to advance and solve suicide in this country. So as a result, SAMHSA stood up the National Action Alliance for Suicide Prevention. It was actually written into the President's Freedom Commission report on mental health in the early 2000s, that there be a public-private partnership, recognizing that was really the way that we were going to advance suicide prevention in this country. So the role of the National Action Alliance is to champion suicide prevention as a national priority, to catalyze efforts around implementing high priority objectives of the national strategy, and to cultivate the resources needed to sustain this progress. So some initiatives maybe you're familiar with are Zero Suicide. Crisis Now was really the underpinning for 988. So we first released this Crisis Now report that said if there was a nation's hotline all rolling into crisis services, that would significantly improve crisis care. And I think, we can see where that has landed us. And then we have a report on transforming communities. This was based on a CDC technical package that really looked at what are both risk factors, protective factors, social determinants of health, as well as who needs to come to the table to think about comprehensive community-based suicide prevention. So these are just a few examples of the ways that the National Action Alliance plays a role. Hopefully by now everybody's familiar with the national strategy. It was first released in 2002, then 2012, and the third update being 2024, which is really a whole of society approach with very concrete recommendations. The 2002 strategy just focused really on suicide prevention being something to raise our awareness and something that we could address. 2012 really focused on what are the evidence-based strategies to reduce suicide in this country, and began to talk about the research behind those evidence-based strategies that we should implement to reduce suicide. 2024 really incorporates advancements in the field. It addresses emerging issues. It brings in much more of a lived experience role. It's really designed to guide and motivate and promote a much more coordinated and comprehensive approach to suicide prevention across different sectors and settings, addressing the risk and protective factors associated with suicides, recognizing no one single solution, no one seminar, workshop, training, community-based intervention will reduce suicide. So the National Action Alliance, just to give you an idea of who we are, we have a public co-chair, we have a private co-chair, we have a steering committee that helps make some of the decisions. We have an executive committee, and then we have advisory groups, work groups, and task forces. So for example, Zero Suicide emerged from one of our earliest task forces that Kate was a part of, the Clinical Care and Interventions Task Force. We continually bring groups together for short periods of time to kind of help launch or really think about one of these initiatives and then sunset it when we feel that we want to move on, because obviously we can't just keep every task force going indefinitely, especially as we've put together things like Crisis Now and other things that now have a life of their own and are really kind of overseen through other coordinated efforts. I mentioned many of these, but these are many of the groups, public and private, that sit on the executive committee. So I'll just leave it up for a quick second. It just gives you the depth and breadth of the types of individuals and entities that sit around the table and contribute to the Action Alliance and its goals and initiatives. Many people ask where our funding comes from. So just a snapshot. A lot of it comes from federal. You can see that's the dark blue. Then we get some private and corporate funding. Some on donations. We have a donate button. So sometimes people donate to us in memory of somebody or just recognizing the work that we do. And then a smaller subset comes from philanthropy. To give you an idea of the strategic priorities that we have currently set, so these are our 5 strategic priorities that we're working on over the next 3 years. Progress, accountability, and data, and that's what Deb is going to be talking to us about today. The idea that we have to, now that we've launched the national strategy, what's its impact? What's our accountability to making sure that we got it right, that we're achieving the outcomes that we want, and how do we continually do better? We have a research group. We need to really think about what's the expansion of research and make sure that all the work that we do is grounded in science and best practice. We continue to advance the crisis care continuum, not so much focused on 988 entirely, but thinking right now we're doing a lot of work focused on transitions in care between emergency departments to elsewhere, between inpatient to outpatient. How do we really ensure that people, because we know that that's a really high risk time for suicide. So how do we really ensure that people are getting care that they need, but also healthcare systems are able to provide that care? The Effective Suicide Prevention and Healthcare Working Group really focuses, it's not just on zero suicide, but other best practices that we can scale in health systems, and messaging and communications. This incorporates things even like, how does Hollywood portray people with mental illness or struggling with suicide? How are we ensuring that those messages that are seen by the public reflect best practice in science? So just to give you an example of what we're working on in effective suicide prevention in healthcare, we're really focused on goal 8 of the national strategy, which calls on healthcare partners to implement effective suicide prevention services as a core component of healthcare. This is the goal by which zero suicide was born, but it's also more than the comprehensive approach that we call zero suicide. It's many of the different effective best practices that we want to make sure providers are using, that providers are trained in, that they're measuring the impact, measuring the outcome. So we've been doing work to really better understand this landscape and figure out where the best opportunities are. What we're working on then specifically here is really how do we operationalize definitions? So when we talk about care transitions, when we talk about data and research consistency, how do we ensure that we're all using the same operational definitions? And how can the Action Alliance ensure that we are at the forefront of pushing this out? Metrics and accountability is a big piece of this. As I said, we're going to be putting forth what we think are the best metrics. And again, Deb will talk a lot more about this in depth. But how do we know that we're making progress? We can't measure everything in healthcare, but we could put forth a few metrics that at the national level that would give us an indication of how well we're doing and how far we still have to go and where we need to pivot. And then under the advisory group, we have a payer working group. And part of this is because we realize the role that payers need to play in terms of funding best practices, funding care transitions, using billing codes, and how well are those been adopted that have been recently released in healthcare? How well have those been adopted by healthcare systems? If not, why not? And what more can we do? So we've been working with a large group of payers to really help them to lead on this and tell us what they could do and how then the Action Alliance could take that further to scale. And with that, I can take some questions now if people have any about the Action Alliance, or wait and take questions with Deb. Julianne, I'll let you monitor chat. I don't see any, but if there's anything, feel free to throw it out there.
Sure. Yeah. Right now, nothing in.
Not hearing any now. Why don't we move forward and we'll have some more time for questions at the end.
All right. Thank you so much, Julie. That was a really great lead into what I'm going to share. Let me pull up my slides. Okay, hopefully everybody's seeing the right thing.
Looks good.
Okay, sorry about that. Okay, well, thank you. My name is Deb Stone, and it's great to be here today. Thank you so much for having me. And I'm going to share with you a little bit today, as was mentioned, about sort of the national strategy, some context for that, as well as thinking about the evaluation and metrics that we can use to assess progress. Okay. So just by way of a little PSA, as was mentioned, I was at CDC for 18 years, and now I'm over at the JED Foundation. And I really want to appreciate and thank CDC for the opportunity to be involved with the national strategy. I had the privilege to co-lead the national strategy along with my friend and colleague, Brandon Johnson, over at SAMHSA, and other folks at SAMHSA, CDC, NIH, and SB, alongside the Action Alliance and SPRC. And so I recently transitioned over to the JED Foundation, and they've been very supportive of my continuation with the work with the Action Alliance. So it's really great to have their support and interest in this as well. And for those who aren't familiar, JED Foundation is a nonprofit that protects emotional health and prevents suicide for our nation's teens and young adults, giving them the skills and support they need to thrive today and tomorrow. And then Action Alliance, as you heard Julie say, I won't go through this, but want to thank them for leading this work and for their partnership over so many years, and just being, great stewards of suicide prevention in the public-private sector space. And I want to also acknowledge co-authors on this, as well as our Hope Counts Advisory Group. This is a picture of us from the recently taken at the National Football League, where we were invited for the day and gave this talk as well there. And so it was really great opportunity. So very appreciative of that. So I have three brief sections today that I want to talk about. Unpacking existing frameworks for evaluating suicide prevention national strategies as part one. Part two, we'll dig into like Hope Counts initiatives specifically, which is really the building blocks for evaluating the national strategy. And then part three will be related to metrics development, specifically related to treatment and crisis intervention. So the first part provides some context for the work of national strategies and evaluation. So here we have three groups that have basically come out, with policy statements over the years, starting from 1996 with the UN, that, really having a national strategy is important. And, it's important to have the need for infrastructure to support this work. And there's a need as well for a comprehensive approach to suicide prevention that is a multi-sector undertaking. And WHO and IASP, or the International Association of Suicide Prevention, also mention the importance of evaluation and implementation of evidence-based work, which you'll see as themes today. So in terms of national strategies and other types of policy documents, the IASP identifies several types of frameworks, including strategies, policy plans, and programs, which are all slightly different but similar in their in the importance of suicide prevention, but they sort of are, they may vary in the depth that they go into in each of those. And a national strategy can be one sign of what they say is a whole of government commitment, and often combines upstream and downstream approaches for coordinated action. And as Julie mentioned, we have a US national strategy that I'll mention a little bit about in a minute. So just thinking about the international work for a moment, if folks are interested in that, I know I am. And, the Action Alliance in this work has really partnered with some international folks, which is really making this project that much more, it's really great to see what's going on overseas in other countries and to learn and share lessons. So this slide shows that results of an analysis that was undertaken to see like how many countries actually have national strategies. And so Altavini and others show that 59 countries have strategies. Most of them are in Europe, and most of the countries are high income. And the International Association of Suicide Prevention and Partnerships for Life is really spearheading an effort to get all countries to have a national strategy. So as part of this work, the World Health Organization, for example, has put forward an organizing structure for other countries to adopt called Live Life. And LIFE is an acronym that you can see there that spells out major suicide prevention strategies. And WHO does recommend monitoring and evaluation as a core component of the architecture of suicide prevention strategies at a national level. And so not just like an add-on at the end. So this is just one example of a particular organizing framework for suicide prevention. So as Julie mentioned, the 2024 national strategy came out recently. We have the same slide, so I won't go through this, but basically it was really a wonderful effort by the federal government. This was something that the the White House had requested that we put out a new 2024 national strategy because the last one had been in 2012, as Julie mentioned, and they're actually only 10 years, so we were overdue for one. So I was able to work on this with across the federal government. We had about 20 different agencies participating in this work. We got support from lived experience, people with lived experience, as well as did a lot of listening sessions and briefings, and really worked to create this whole of society approach. And we're really proud of the work that came out. And there's also a federal action plan that goes with this that has over 200 actions that the federal government had committed to. And this is the first time that we had a federal action plan. So it was really amazing to help with that and to see all the great work that, you know, as Julie mentioned, so many partners across the federal government in the National Action Plan, you know, were involved from transportation to the VA, military, housing, you know, HHS, of course. So many partners. It was really just goes to show how widespread suicide is as a concern amongst the federal government, but also more generally in the population. So these are the 4 strategic directions. And as was mentioned, as I mentioned a minute ago, you know, national strategies often include both upstream and downstream suicide prevention. And so our strategy is no different. A lot of the upstream work comes in the community-based suicide prevention, where we're looking at the development of partnerships and coalitions, the integration of suicide prevention into different community organizations and into workplaces. It also includes lethal means safety. It includes communications and making sure to use evidence-based practices for campaign development. It includes a big focus on social determinants of health and comprehensive prevention more specifically. And then we have a large section on treatment and crisis services as strategic direction 2, which is focused on the many advances in suicide treatment and crisis intervention, including the need to prioritize suicide prevention within healthcare systems, as Julie mentioned, through programs like Zero Suicide. It also provides recommendations for intervention along the crisis care continuum, including 988. And then, of course, undergirding all of this work is the need for really quality data and research and surveillance. So we have a bunch of recommendations and goals and objectives under this section, and then health equity and suicide prevention, which really incorporates a lot of the items from strategic directions 1, 2, and 3, with a focus on populations disproportionately affected by suicide, and making sure that all of these things that we're saying are necessary are being brought to communities that are most impacted, and that those communities are engaged in this process and in all of the work that goes on, including the research, the data, all of it. You know, how much do these national strategies, you know, how much difference do they make? Well, there was a meta-analysis done recently, and it included 28 studies examining suicide rates before and after national strategies, and included multi-country studies and also single-country studies. And maybe not surprising, there was mixed results. And so the authors note that the literature examining their impact on suicide-related outcomes is of modest methodological quality, precluding a definitive conclusion about effectiveness. So basically, none of the studies reported on implementation status, and that really limited the interpretation of effectiveness. You know, the jury is sort of still out on whether these actually make a difference, but we know from this paper and from others that without implementation data, there's no way to know if strategies are ineffective or simply under implemented, or if hopefully that they are effective. So we really wanted to make sure that when we put together the national strategy, this new one, that we're going beyond just saying like, okay, we have a strategy, now let's put that on the shelf. We need to start examining the continuum of implementation from inputs to short, medium, or intermediate and long-term outcomes. And that's what this whole Hope Counts initiative is all about. So again, we learned that implementation matters, that evaluation has to be embedded from the outset, that we need to strengthen cross-sector accountability, including those public and private sector partners. And we need to invest in data infrastructure to really accelerate and move the field forward. So that was some background. Now I'm going to go into the Hope Counts initiative more specifically. And so again, Hope Counts is being led by the National Action Alliance for Suicide Prevention that you heard about, and specifically the Progress, Accountability, and Data Advisory Group. And this group is charged with, you can see at the bottom there, designing and implementing the evaluation of the national strategy, selecting and strengthening core metrics and data systems, supporting transparent reporting and use of findings, and ensuring the long-term sustainability of the effort. And it's really important to note that this evaluation was actually written into the actual strategy. So there's an objective like that says, we must evaluate this national strategy. And not only we, but the National Action Alliance for Suicide Prevention, in conjunction with the federal government, should be joint stewards of this action, of this evaluation. So that's exactly what we're doing. And then I want to mention that Richard McKean was the SAMHSA public sector co-chair. He has since retired, and there'll be a new public sector co-chair, and he is joined by Vic Armstrong from AFSP as the private sector co-chair. So Hope Counts, I want to first say what it is not. It is not the evaluation plan, but it is an evaluation framework intended to serve as a blueprint for evaluating the national strategy. So this framework offers a governance and decision-making structure. It also provides a theory of change along with nested logic models that can support state, tribe, and local alignment with the national strategy, implementation, and evaluation. And I'll go into more depth about that in a minute. It describes the plan for identifying metrics and creating a data improvement plan, and strategizes on issues of dissemination, partnership, and resources, and provides a high-level timeline for implementation. So that's what Hope Counts is. This is our theory of change. This is a major component of the Hope Counts initiative. We created this visual to depict essentially how we see the inputs that come from the national strategy. So examples are workforce capacity, financial, material resources, and other things that are supporting those goals and objectives within the national strategy, and activities, again, that are specific to the national strategy, and how they work together to lead to different outputs of reach, quality, efficiency, and progress. And then from there, we're able to assess short-term, intermediate, and long-term outcomes, with obviously the biggest outcome that we're looking for is reduced suicide mortality, but also morbidity. So this helps us to visualize the process and to keep us honest that we are actually following through on the process in a way that's very deliberate and intentional. And to go along with the theory of change, we also devised this concept of nested logic models, which will help depict how federal, state, tribal, territorial, and community and local organizational work aligns together with the national strategy, goals, and objectives. And the idea here is that these nested logic models, which I'll show you a visual in a second, all of these will roll up and contribute to the broader national framework and its evaluation. We know that we can't have everybody, we're not going to be able to track all of the logic models across the whole country, but we'd like to get folks to start putting these together for themselves in their communities, so that we're building capacity, we're building that infrastructure, we're building and leading, our ability to track progress and eventually outcomes, and developing this structure that supports shared metrics and allows contextual flexibility so that different communities will be doing different things. And so the benefits are nested logic models are here: identification of gaps and overlaps in implementation in different jurisdictions, development of common core metrics that we can use across these different entities, coordination of public and private sector contributions, and shared language on progress across the field. So this is all of what's being developed as part of Hope Counts. And so this is sort of a visual of the nested logic model. So on the top, you see the national level theory of change that I just mentioned. And then at the local level and also state, tribal, territorial, there will be there'll be a series of logic models and activity that's going on at that local level that all together can roll up into our theory of change and help us to assess progress and impact. So basically, in a nutshell, the state, tribal, territorial, or local priorities to national strategic objectives will be mapped. We'll identify intersections between local strategies and national outcomes, align metrics where feasible, and use crosswalk tools to visualize shared drivers and impact pathways. And so some of those tools to visualize would include things like having a data dashboard, which we hope to do, where we can like literally click on a link, go to a website and see the progress being made. That's kind of like one of our visions for this work. So speaking about the core metrics and data improvement plan, this is going to be front and center key to this work. So we want to develop metrics that we can use to help assess progress and impact. This will be a top-down, bottom-up approach. At the top level, we'll convene expert panels to review the logic model to articulate metrics that we can use related to each strategic direction in the national strategy. And then from the bottom up, we'll invite small teams to review the literature and conduct key informant interviews, identify available metrics related to, again, the major focus areas of the national strategy. And this will produce a comprehensive list of existing and needed metrics. And when I say comprehensive, I don't mean one metric for every single goal and objective. I mean a succinct group of metrics that together can help assess progress. And those metrics should abide by these different characteristics here on the right and be things that are, for example, applicable, valid, actionable, feasible, and you can see the rest. So there needs to be a really rigorous, these metrics need to show rigor and be something that we can really lean on to know that when we measure these things, that they're actually valid measures and that they're helping to assess progress. And so we're trying to produce a list of 5 to 7 core priority metrics for telling the story of the national strategy for different strategic directions. So that's about Hope Counts. And now a few minutes about the metric development, specifically related to suicide prevention, treatment, and crisis intervention. So this is a little bit like a cooking show where, you see the person and then they put all the ingredients in and then they're maybe baking a cake and then they, put the cake in the oven and then you come back after a commercial and voila, the cake's done. We're not done with the cake. We're sort of in the cooking phase, but I wanted to share that, I mentioned we were going to have these panels, we're going to do all this work. Well, we already did actually have the panels and we have already started. So we're in the middle of baking this cake here. So Hope Counts, there was 2 meetings, and for full transparency, I actually wasn't at either meeting, so I can't answer specific questions, but I was involved with the planning and know about these meetings. So we had 2 panels. The first one was in May to develop a national framework to articulate progress on strategic direction number 2 of the national strategy, which you saw was related to treatment and crisis intervention. So that's where we're starting. The goal of this panel is to identify a focus set of meaningful, feasible, and actionable metrics. So some of those characteristics that I mentioned to highlight areas where measurement is still needed for development. Because we know in suicide prevention, and I'm sure many of you know, that there are so many gaps in data and what we collect and how much we collect systematically. And so we need to also not only identify metrics, but also identify where there is gaps so we can create a data improvement plan. The second panel virtual took place on June 8th. and identified a framework to help narrow the scope of strategic direction number 2 from the national strategy. It consists of 3 domains, which we're calling the 3 C's: care practices, context and tracking, and coverage and reach. So I'll say a little bit more about the 3 C's in a second. So here is, kind of the concept as it was developed. And I really want to give a hearty shout out to Kristen Quinlan, who really led a lot of this work to develop sort of this concept of the 3 C's and how we're going to go about identifying metrics. So again, we're trying to identify a select set of priority metrics, and we need to sort the 15 objectives. So within strategic direction number 2 on treatment and crisis intervention that I mentioned, there's 15 objectives. And so what we did was to categorize those under our 3 C's of coverage and reach: context and tracking, and care practices. So I'm not going to read all these objectives, but I'll just leave it here for a second so you can kind of see what types of things that are in the national strategy if you haven't seen it, especially related to the strategic direction that probably impacts your work to a significant extent. And if you look at these objectives, this is not like fluffy stuff here. This is like really, in-depth things that we're trying to accomplish that includes things like expand timely access to crisis assessment, intervention, and follow-up, to standardize suicide risk identification, treatment, and follow-up in healthcare. I mean, these are really boots on the ground types of things that need to be done. And so we want to identify metrics that go along with some of these to help us assess progress. And so I invite you to think about maybe which one of these objectives you specifically can, position yourselves within, and think about, okay, well, if I'm somebody who focuses on 9.5, like what are some metrics that I either know about or am interested in? And then if you have ideas for what some of those metrics might be that you've been really trying to grapple with or know of, or there's gaps, you can definitely let us know, and we can kind of add that to the information we're collecting. So again, categorized in this way, selected metrics could provide important information on progress on the national strategy. So again, sort of going back to this idea of like the theory of change. So if we can measure, coverage and reach, care practices, and context and tracking, we would be able to answer questions like, is the infrastructure growing? Is access improving? Access to care? Is continuity expanding or strengthening? Is measurement becoming more robust? So, start to put together this story, put together this picture, looking at how these metrics can help us move the ball down the field, and thinking of maybe a soccer analogy. And all of this could help inform a national narrative or a story on the progress, support for sustained federal investment. So in other words, if we know where there are gaps, or we know where there are things that are happening that are going well, but we need to scale up, we can actually share that with policymakers and others in decision-making roles to help get more resources. We can respond to gaps and see requirements for measurement improvement, as I mentioned. So again, the key framing concepts and strategic questions. It was stressed to these panels, we are not attempting to identify, as I said, every possible metric or to rank them by quality. But what we are trying to identify is strong existing indicators, promising but partial indicators, and critical measurement gaps in these 3 areas that relate to the goals and objectives in those areas, and a reminder, of the guiding questions. So basically the group was, told, given the guiding questions on the right, if you could only track 3 to 5 things nationally for across these areas, what would they be and why? And so this is what the panelists really talked about and spent some time, really thinking critically about. So again, other questions that were also posed to the panel is like, would the metric, once you've identified something, be appropriate for a national dashboard? Would policymakers and advocates and other key partners understand it? could this realistically be updated over time? And does this represent something strategically important? And again, do these metrics kind of are these characteristics of really robust metrics, being represented by your metric? Are they feasible to collect, understandable, timely, all of these things? So this is really a heavy thought exercise, and we invited people to really come up with those key metrics. When we talked about the top down and bottom up, we have these expert panelists, and then we also did an environmental scan and came up with some possible examples of metrics from the data. And so obviously there's a lot here, but you can, start looking at these and see if any of these ring true to you, or, oh yeah, we're collecting that, or, oh yeah, that's something we should collect, or, oh yeah, that's something that would be really critical for the field overall. So, I invite you to, really think about the work that you're doing and how you assess progress and change and impact, and whether or not those things would be replicable and important for on a national level. So just keep that there for a second. Okay. And then finally, this is sort of bringing us back. We have the national strategy at the top, the strategic direction. We're focusing on right now. We're going to go through this exercise for all of our strategic directions. That's the plan. So looking at treatment and crisis intervention as strategic direction 2, we're looking at the 3 C's: care practices, context and tracking, and coverage and reach, and reviewing the top candidate metrics in each of those domains. And then we'll review the data sources and feasibility, as well as those other characteristics that I mentioned. And then there'll be a selection of candidate metrics in tier 1, tier 2, tier 3, strong, existing, and other metrics that in tier 2 that are important, but maybe they're only partially available or need more work. And then tier 3 would be like critical gaps. And then this is where, you're waiting for the cake to come out of the oven, because I'm not going to be able to share with you today what these metrics are, but hopefully I have, whetted your appetite a little bit, because we hope to share the next phases of this work and what we've found through this process in Costa Rica, potentially in November. Well, there's the International Association of Suicide Prevention has their Pan-American Conference beginning of November in Costa Rica, and we're putting together a panel to discuss evaluation of national strategies, not just the US, but others as well. And we hope to kind of roll out some of what we've found so far. So next steps are to follow up on the metrics panel and identify those metrics for strategic direction 2, demonstrate how the selected metrics support transparency, accountability, and continuous learning, create a storyboard, and develop a proof of concept for a public-facing dashboard that we hope to get funded, and really work to develop partnerships, including people here today who may be interested in supporting this work and thinking about a nested logic model, like how does what you're doing actually roll up into one of the goals or objectives of the national strategy, and what types of metrics do you have that might be available on a national level. So please let me know if you have any thoughts or you're interested. Thank you so much. It's been great to tell you about this work, and I will go back to Julianne and others to take some questions.
Yeah, so people, if you would like to put a question in the chat, you're welcome to do that, or you're welcome to take yourself off mute um, and to just ask your question. I know one thing that is interesting to me is this idea of the nested logic models, and thinking about how we might be positioning our work in terms of being a local
Yeah.
model, and so my sense is that a lot of this work is in the public health space, and I was kind of curious about, within the healthcare world, like how are healthcare entities, participating, and are there insights, perspectives that they have
Yeah,
uh, inside of healthcare that might differ from the public health.
yeah,
Uh,
thanks for asking that. That's great. So yes, so couple things. So the national strategy is a whole of society approach. So it does take sort of the broad frame is like a public health framework. We're looking at upstream and downstream activities, goals, and objectives. But within those specific strategic directions, you have a variety of stakeholders, if you will, including health systems, including education, including workplaces, and community organizations, and so many different entities. So there's a place for everybody within the strategy. And so within the strategic direction too, on treatment and crisis intervention, we have 15 objectives. And I'm guessing that the work that you're doing, Kate, in the center is doing falls within at least one, if not more, of those objectives. So then the idea is to think, okay, we're doing this work. Can you lay out your logic model showing what your inputs and what your outputs are and how they lead to short, medium, and long-term outcomes? And then if you can do that and we can align on maybe some metrics, we can that could help with the overall picture of creating progress. And we know we're not going to be able to have all these different nested logic models that we're collecting necessarily and evaluating, but we're going to leave it up to local teams to do that for themselves. And hopefully together that creates some momentum across the field. And so if we have some common metrics, we can actually see progress. So would definitely invite you and your team to think about how if you can, place yourself within one of those objectives and create one of those logic models and come up with metrics that may be useful for the field.
One thing that comes to mind for us is trying to understand how well the medical record can represent suicidal
Mhm.
behavior when we try to scale implementation level projects. And you're talking, tens of thousands or hundreds of thousands of patients or clients involved, then it certainly is uh, the idea of at the research level where we work, where you're trying to get, report from each participant. That's a very challenging
Right,
way to collect data. On the other hand, what level of misclassification might happen if you're collecting it from the medical record? And are there ways of kind of, we have data from our participants as well as data from the medical record, and we're looking at sort of harmonizing that data. And that's one of the things that we're thinking about a lot this year is, are there ways of thinking about how you might sort of improve the ability of the medical record data to represent what our participants would tell us if we could talk to them
right.
in
Yeah,
person, because otherwise, of course, people are going to scale with medical records data, but we know that there's some limitations to that
right,
data. If people didn't seek any medical care, it's probably unlikely that it
right.
will appear in the medical record.
Right. Yeah. So what you're identifying are, some things that if these gaps could be filled, maybe they could be scaled to other, health systems. But it's really important to identify what those gaps are and how to best fill them. And we know like there's yeah, such a wealth of information within the medical records. And I hear what you're saying too about sort of, some missing information and all of that. So this is definitely part of our treatment section in the strategy and, using electronic health records sort of as your input and the patient experience.
Hey, Deb, let me ask you a question that I know you went over and maybe is really clear to everybody, but it is a question that when we talk about the data and metrics dashboard and hope counts, I know I get a lot. So
Yeah.
in case somebody's thinking it and hasn't asked it, I'll throw it out there. And that is explaining the difference, what these metrics will look like nationally versus individual hospitals each going in and entering a data point, even if it's that is not the purpose, that the purpose is something that can be collected at a much more macro level, as opposed to every hospital saying, 30% screen positive for suicide or something like that.
Right. That's a great question. So yeah, I mean, basically, it's not like either or. Both things will be happening. So there would be the very specific measurement and tracking that's happening at the local level. And also, if we can identify a core set of metrics that people can use across the country, then we'll at least be able to look at those metrics and the progress that's being made in those areas, as because we just can't, there's going to be so many different ways of so much data, there's tons of data that needs to be tracked, but if we can come up with a core set, we can at least track those nationally and locally and at the state level, and then roll that up into our theory of change to see if it made a difference. But absolutely all those other things will be still happening on the ground, if that makes
That's
sense.
great. Matt, it looks like you have a question.
Yeah, hi, thanks. Thanks, Deb, for this overview of everything. I have a question about the action items that were the companion to the national strategy. I
Yeah.
have a question a little bit selfishly because I worked with Richard on a specific item around including a mobile crisis team tracker as a sort of national resource that could be used. But I don't have a good sense of like what does measurement of implementation of those actions look like and sort of like accountability to follow through on those 200 plus different concrete sort of steps that the nation could take. So I'd be curious, like, how are you tracking the outputs and then like aligning that with any outcomes that you see result from implementation of the strategy, especially thinking of it in like a component analysis kind of way to understand like what are the active ingredients that are actually underneath any signal that we might see as this all gets implemented.
Yeah, great question, Matt. Thank you. So what you're pointing to is something that's a little bit of a sensitive area, but let me dive right in, which is the fact that we have this this wonderful treasure trove of actions that the federal government committed to back in 2023. And since that time, and this was the first time that we've ever had that, we had over 200 from over 20 agencies. And so we had asked the agencies, can you come up with like 2 or 3 actions? We got 200. So, I mean, this is just like unprecedented, incredible, like commitment. There wasn't any funding that actually came with those activities, but they were things that people thought would be possible. Well, we were working with the VA actually to create a tracking system for all of those actions. And that fast forward to 2020 to the election and the new administration. And so there's been some changes in some priorities. So, and changes in staffing at the federal level. So a lot of the tracking of those actions is really going to be up to the specific agencies who've signed on to those. So instead of having like a national dashboard where we're showing all of the actions and the progress towards those 200 actions, right now it's sort of like, okay, well, it's up to, SAMHSA and NIH and CDC and HRSA and FDA and all of the agencies to track their own progress. So I don't have an answer for you, but unfortunately, that was a little bit of a disappointment for us and some, fallout from changes. But that, that's what happens when administration's changed.
No, totally appreciate that. And thank you for
Yeah.
fielding the sticky question.
Yeah, no
And
worries. I don't work for
totally
the federal
appreciate
government anymore, so
lots out of our control. Right, exactly. You're in the clear.
yeah,
But no, super appreciate that. Thank you.
yeah.
Not hearing other questions or yeah. So we wanted to say thank you again. There's an evaluation link that Julianne has put in the chat. So we encourage you, as always, to give us some evaluation feedback on our presentations. And Julianne, you're going to let us know what's up for the August presentation.
Yes. Next month on August 5th, we will have Dr. Sarah Danzo joining to speak about her K Award, which was adapting the safety A intervention for pediatric clinics. And she has a cool tool that her team have developed that she'll show and tell. So we're looking forward to that.
And thank you so much, Julie and Deb. So appreciate getting this national perspective. I think it will make all of our work better.
Thank you so much. It's great being here.
Take care.